I'm Farah Duro, and you're listening to the PCOS Revolution podcast. Hello, and welcome back to this week's episode of the PCOS Revolution podcast. Now, in honor of National Infertility Awareness Week, I recently did a live Q&A with Dr. Kenneth Gelman of IVFMD. And in this interview, we answered questions from our audience on Facebook and Instagram. And I have to admit, every time I do a live Q&A with him, I learn something new. So I hope you enjoyed this interview as much as I did, and that it brings you a little light if you're struggling with trying to conceive. Even if you're not trying yet, I encourage you to listen to this episode or share it with a friend in need. Okay, guys, let's jump in.
Hi, everybody out there in Computerland. I'm Dr. Kenneth Gelman. I work in IVFMD, which is a large practice in South Florida. I think we have several offices and a lot of physicians, and I'm in the Cooper City location. We specialize in obviously infertility, but all aspects, I would say, in reproductive endocrinology also. So obviously we do see quite a bit of women with irregular cycles and PCOS particularly. But essentially the practice focuses on IVF very heavily and ovulation induction and those techniques. But, again, we see women from all the spectrums, from younger to perimenopausal in addition to. So it's quite a varied practice. But PCOS does make up a large bulk of the patients that I see every day.
And a lot of times we get questions about if there is a practice that is integrative that focuses also on nutrition and lifestyle. And so we've worked with IVFMD several years, and we definitely see that is one of the focuses too. It's basically thinking outside the box a little bit because everyone's different. Every situation is different. So that's one of the beauties of it, of working with Dr. Gelman and his practice. And we actually do fertility acupuncture, reproductive acupuncture at Florida Complete Wellness. And we work with PCOS, endometriosis, infertility, and also working a lot with stress relief, helping with blood flow, and pain as well. So we're here today because we want to actually give a different view of what things come up for our patients who are undergoing fertility treatments. And also if we do have questions pertaining to any kind of reproductive issue, definitely feel free to ask tonight, because this is your chance. We're going to have actually a 45-minute live session, and we'll be able to definitely address your questions as they come in. So even if you guys on Instagram would like to ask, just type into the chat. We do have a few questions from earlier today that you guys posted. So we're going to go ahead and start with that. So one of our first questions is actually from a person who is in our PCOS Revolution online program. And she's actually in our 90-day group, and she's actually having issues with irregular cycles and PCOS, and also wants to know how to address low progesterone. So we're going to read a question here. Why is progesterone low or non-existent in some women with PCOS? And do some women require bioidentical hormones for years until the body can make its own? Is there anything that can be done to help the body make more progesterone?
Well, that's a good question. I mean, I think the hallmark of PCO, in a sense, is the lack of progesterone, because many women with PCOS just don't have the regular menstrual cycles that normal cycling women have. In other words, they don't manufacture their own progesterone, which means they don't ovulate regularly, but they do intermittently. And we know that some women, even with the PCO, who have a very irregular cycle, can sometimes spontaneously conceive, so they must have ovulated. But, it's not something that, and again, depending on the individual, what type of PCOS they have, and there's several different types out there now. And that's one of the quandaries a lot of doctors are having now, is how to define PCO and PCOS. But if you look at a classic case of PCO, which typically involves a woman who tends to have, is weight challenged, may have facial hair acne, doesn't get a period at all, or has very scant periods, maybe 1 or 2 a year. They may be severely insulin resistant to the point where they could be pre-diabetic in many cases. Many of them are hypertensive. Those individuals generally don't manufacture progesterone each month because their follicle in their ovaries, or every month a woman makes a follicle that tends to ovulate, they don't do that. In other words, the follicles don't mature. So we have to give them progesterone to, replace what the body isn't producing. And that usually induces a period. So many women are on Provera, or they're on birth control pills, which gives them the progesterone included with the estrogen in the birth control pills. So we're sort of replacing what the ovary isn't manufacturing. So the goal really in those women is to try to get them to cycle. That's how you can produce your own progesterone if you cycle on your own. So the goal is obviously to include a lifestyles evaluation, which we just briefly discussed, and that includes, careful nutrition, weight loss, attention to proper sleep and proper exercise, stress reduction. Those factors we do focus on. In addition to helping them achieve insulin sensitivity by helping them lose weight, obviously exercising, but also adding metformin. There's other things out there. Maybe berberine might be of value to some of these people. Or if they're trying to get pregnant, we make them ovulate with the ovulation-inducing medications such as Femara or clomiphene or injectable gonadotropin shots. So these things help to make the follicle mature so that these patients can ovulate and produce the requisite amount of progesterone that they may need, for that particular part of their lifestyle, whatever they're trying to get involved with.
So then that question is basically it's due to irregular ovulation or trying to help someone who is not ovulating frequently. Their progesterone is going to be chronically low because there's no corpus luteum producing that progesterone, right? So.
Correct. So if you look at a blood level of progesterone, is usually 0.4, 0.3, 0.2. I mean, it's very low in the blood. You don't really need a lot of progesterone unless you're ovulating and trying to support a lining in the uterus, for potentially a pregnancy, et cetera, et cetera. So, but we do need to manufacture progesterone to help the endometrial lining resolve itself each month, because you don't want the endometrial lining thickening too much under the influence of estrogen only. You want to have a progesterone effect there to cause a withdrawal bleed, so the endometrium or the lining uterus cycles at least 6 times a year in order to avoid any particular disastrous complications, which rarely can occur in some women, such as what's called hyperplasia of the lining of the uterus. You don't want to have that. So that's why progesterone use is done in these women, is given to these women for that reason.
And so as far as somebody who is trying to conceive and they are checking their progesterone level, they just found out they're pregnant, what's a good progesterone level to look at?
Well, we always look at, we like to see it over 15, we use an arbitrary number of 15, but on occasion we see lower ones, and those pregnancies go to term. I remember I've had a couple of cases of progesterones of 5 and 6.
Oh, really? Wow.
And they have gone to term. So it doesn't always predict what could potentially be happening in that particular pregnancy, but it's always reassuring when you see a nice high level. And in stimulated cycles with ovulation-inducing drugs, we see much higher levels of progesterone.
So that was my question. Yeah, if you're given a progesterone suppository, is that going to show up in the blood work?
Very little. It's absorbed very, very little. So if you're on progesterone suppositories, if you're doing an ovulation cycle, the progesterone that you measure in the blood generally reflects what that person's ovary is actually doing, and very little from the suppository is actually getting measured, but some does. Some does.
Okay, so then would you recommend progesterone injections for someone who is low in progesterone generally, even if they ovulate, who are going through maybe an IUI cycle? Usually you don't use injections for IUI, correct?
No, I don't. We usually don't use progesterone in IUI or those types of cycles unless the progesterone levels are below 15 or 12 or 13, 10, we might put them on that to help implantation, to keep the levels higher. But we don't use IM progesterone just in IVF situations.
Okay, that's a good question. And some people wonder what the difference is between Clomid and Femara. For PCOS, or also somebody who is trying to conceive, but they're not to the point where they're doing IVF yet.
Well, they work a little differently. I mean, Clomid is the drug that's been around for a long time, probably 50, 60 years. It's an anti-estrogen drug. It works by blocking estrogen feedback on the pituitary gland. It fools the brain into thinking you're low in estrogen. But it's also an anti-estrogen in other tissues of the body, particularly the endometrial lining of the uterus. So in some women who've taken multiple cycles of clomiphene tends to hang around the body a long time. It has a long half-life. So it may tend to thin the endometrial lining in some women after prolonged use, usually after 3 cycles and usually higher doses.
Okay.
But it's a time-honored drug. It's been around for a long time, and obviously there's been plenty of pregnancies on it. But it's found recently that Femara, which is an aromatase inhibitor and actually blocks estrogen production, works differently. Doesn't thin the endometrial lining, and tends to induce usually more of a monofollicular ovulation in most cases, but occasionally we get a twin on it. It seems to work better in PCO. There's been studies now which seems to be the preferred oral ovulation-inducing medications. As a matter of fact, there was a study, I think this month, in Fertility and Sterility, where the 2 drugs were combined for ovulation induction, and they actually found a higher ovulation rate in PCO, women who were resistant to either one or the other drugs. And actually, it looked like a higher pregnancy rate, although they said it wasn't statistically significant, but the ovulation rate was much higher, actually, when both drugs were combined, which I found was interesting.
Definitely, we've seen a Chinese herbal medicine used with Femara and also Clomid. There's research that has shown that actually it helps it work better in certain cases. So a lot of times we get asked the question of, when should I stop my supplements? And, is it okay to take Chinese herbs during a medicated cycle? And definitely there's, I think, a communication that has to happen between the fertility clinic and also the provider. So if you're able to communicate, if your acupuncturist is able to communicate with your IVF doctor, I think it's really important. And what we do generally is, if a patient comes here, we ask that they do have at least 2 or 3 months with us to just prep for an IVF cycle coming up, if possible, because that gives us time to actually help reduce cortisol levels, help with blood flow, and also set the stage for a healthier pregnancy. And if we are using Chinese herbs, we want to use those herbs prior to any start of a stimulated cycle, like with injections, because Chinese herbs can sometimes interfere with the hormone levels that are going to be, the doctors are relying on to see how well you're responding to the medications, especially estrogen. So sometimes the herbs contain phytoestrogen. So we just want to make sure that we're not interfering with the medications as well. And, usually that's, if we have, a couple of months to work with someone prior to an IVF cycle, that's plenty of time actually to take the herbs or any supplements needed. And then you also, I know you guys use supplements in the clinic, so you're actually going to tell patients to stay on those supplements throughout the cycle too. And some of them you're continuing, but some of them you're actually saying, to go ahead and discontinue. So what about someone who's taking like CoQ10? We have that question come up, like, should I continue it after stimulation or throughout, to the transfer, or when's a good time to?
I usually have them stop it, by that time. And, if they're on DHEA, we use a lot of DHEA in women with poor ovarian reserve, because it seems to, several studies say no, but several studies say that it may improve the quality of what eggs are available there. That helps bringing them up to the surface, because it may help improve the androgen environment in the ovary, which is permissive to other hormones bringing eggs up. So we do use those kinds of drugs quite a bit. And I tend to stop them, usually when they start their stimulation. But certainly by the time if they're transferred, I don't have them on any of those. just prenatal vitamins.
Prenatal, D3, or
And
omega,
vitamin D.
yeah.
Yeah.
And
Fish oil.
the fish oil, yeah. And those are our standards. And, a lot of times what we do is also we give a Mediterranean menu plan to our patients so that they can start 6 weeks prior, at least, with both partners. So husband and wife or partners, both of them involved with cooking healthier and taking then natural antioxidants in. And there's actually research studies that showed that they had better IVF outcomes when both partners were actually on the Mediterranean diet. So we use a gluten-free Mediterranean a lot of times because our patients also don't want to gain weight going through IVF. So a lot of times they do put on some stress pounds, and we see some people coming off of cycles that have gained a few pounds because they've stopped exercising or they're actually eating more because of the stress of everything. So we like to actually help prevent weight gain also during that time and have a healthier diet. So we actually ask our patients to start this prior to, and that's another reason why it's important, I think, to start prepping ahead of time. So we look at it like, this is the pregame warm up, and then you're going into the big game actually prepared instead of, I guess the equivalent is just running a marathon without any training. So I think it's important to be prepared to go into it. It is a big thing. It is stressful, but there's a light at the end of the tunnel. And when you come out of it, sometimes it feels like a big blur, just like, wow, that all just happened. But then 6 weeks, it was, from start to finish. But it's important to prep yourself as well. So what do you notice with your patients?
Well, I was just going to add that that's, an approach to reducing inflammation as much as possible, essentially, which is a Mediterranean diet is probably the best at that. Because, very little or no red meat, things like that.
Yes.
And, a lot of patients may be on metformin for that reason, to help reduce inflammation, insulin resistance, and the supplements, some of the other supplements that I didn't mention. But, these things are all designed to keep inflammation out of the body, because if you have inflammation, you're inflaming your eggs, essentially. So we want to try to avoid that. So we want to try to get the highest quality eggs. And that's what we try to do either ahead of time. And certainly if patients do poorly, we make sure they're on a diet such as this afterwards to try to improve things for the next time. Because, these things really seem to help.
Yeah, and it's actually not a bad Mediterranean diet's pretty delicious. If you like seafood, it's easier. Yeah. So, and as far as when we look at someone who, you mentioned that if they didn't do well from a previous cycle, then talk to them about the diet. But do you actually think, like, when people come in to start an IVF cycle, they have actually a few months, right, from testing and checking the tubes and checking out all the parameters, especially if there's any complications with checking the immune system and all of that. So there's a little bit of time to prep before you usually don't just jump right into IVF, or what do you usually tell patients as far as time wise?
Well, I mean, depends on the patient. There's a lot of information out there, and some practices are just going to basically get, if the patient's older and has diminished ovarian reserve, they're going to try to get the patient in quick, and they're not going to delay the patient, with, weeks and months of diet or DHEA, things like that. I mean, there's some people who just don't believe in any of that. They don't think it really matters. It's much better to get them through and get the eggs out or fertilized quicker, but I tend to think that, health is very important. I think if we can reverse some of these things a little bit, to what extent, I'm not 100% sure, but I think we can help improve the outcome in subsequent cycles and by doing things that promote good health. And that's what we're all about. I mean, if they're overweight, if they're eating poorly, or actually if we have them do a panel of inflammation, we can actually detect which inflammatory mediators are elevated. And we could try to target those specifically and repeat the inflammatory panel in 6 weeks and see if it improves, then put the patient through.
Okay.
So those kinds of things. So you can actually use some objective data to actually show the patient, they're doing better. And in many cases they are.
So it takes about 6 weeks, would you say, to see a difference in those inflammatory markers? And you wouldn't recommend someone if you did see elevation in inflammatory markers, then would it be contraindicated to actually start them on a cycle right away?
Well, I probably, try to avoid it. I mean, I think those people probably may have the risk of doing poorly. I mean, it's hard to say for sure how they're going to do, but this is something I think we need to maybe focus on and try to, say to the patient, listen, we have these issues here. Let's try to improve these things first before we actually put you through the cycle. But again, it's going to depend on the patient, depends on their ovarian reserve, their age. A lot of factors go into those decisions, though. So some people may not, be going through, and 6 weeks later they may be going through sooner.
And then, do you have a name for that test that you guys?
Inflammatory panel.
Okay, so it's something that someone can ask their doctor for, or is it something?
Well, we have a specific panel. I mean, ours is specific to our practice. I mean, I don't know what other doctors are doing. I know cardiologists do inflammatory markers all the time.
Mm-hmm. Yeah.
They may be doing a different panel than we're doing, but we actually look at several things.
So inflammation's a whole nother topic, but I think with endometriosis, we see that quite a bit. With PCOS,
absolutely.
there's definitely that.
And that's why, these are important, definitely with endometriosis. That's why I think fish oils are very important as part of
yes.
part of your diet plan.
Yeah.
And
everybody gets fish oil.
Yeah.
High potency one too,
Yeah.
a good quality one is important. And throughout pregnancy as well, it's important for the brain development too. So I think things that you can do to prep for pregnancy are also important, like vitamin D levels. You will not start someone on a cycle, right, you won't do a transfer unless their vitamin D is at a certain point. So what is that threshold for you guys?
Well, minimum of 30. We want to get it up maybe 50.
And I think the optimal range is between 50 to 70, right, for reproductive age. And I know we get a lot of confusion on thyroid, which is another question that popped up that I had from a patient. She was actually surprised about thyroid ranges being a little different for reproductive age women than not. So what is the...
Well, it's really, I mean, when you look at, we look at a lot of thyroid profiles, and there's something called gestational hypothyroidism. It's kind of a newish entity.
Okay.
And it really looked at, TSH values above 2.5. So TSH is the main test you look at to determine somebody's thyroid status. I mean, if you're going to look at any one test on the thyroid panel, it's a TSH.
Okay.
And those are very sensitive assays. So anything above 2.5 in a patient, who's going to try to get pregnant or certainly is pregnant in the first trimester, they should be supplemented with thyroid pills to keep the TSH below 2.5. 2.5.
Okay, because that's not going to be flagged when you have your thyroid done. It will not flag it.
Because if you go to your regular doctor and your TSH is 2.8, it's fine. It's in a normal non-pregnancy setting. That's a normal TSH, and your primary care doctor is not going to bat an eyelash at that. I mean, he's going to say it's normal. Why should I supplement you? But in this situation, in the fertility realm, it is elevated.
Okay, so then someone who has over 2.5 TSH, they probably need to look at talking to the doctor about a Synthroid or something like levothyroxine.
Right.
And as far as during pregnancy, do you know if that's a similar range or what?
I'd keep it below 2.5. I'd have the OBGYN check it each trimester.
Okay. So we have
because without getting too technical, there's particularly in the first trimester, there's a lot of changes in the body. The body, a lot of iodine. Iodine is the important molecule that makes up thyroid hormone. Iodine gets passed to the developing baby, but also a certain amount of it gets diuresed or passed out of the kidney because there's changes in your kidney function. So, and there's also changes in what's called binding proteins, where a lot of the iodine and thyroid hormone gets bound up because of the changes in pregnancy from the estrogens and things. So thyroid hormone has to be increased, into the first trimester, towards the end of the first trimester, to account for the fact that there's so much changes in the amount of protein-bound iodine.
We have some comments coming in. Rachel says, just wanted to say hi to two of the best. Oh, thank you, Rachel. Wouldn't have my daughter without the two of you. Oh, that's very sweet. We appreciate it. And then Christina says, Dr. G, you're my hero, and I will be forever grateful for you. Oh, thank you, Christina. And Katrina is asking, which vitamins are the most important to check on women attempting to regulate their cycle? So vitamin D3 we mentioned. Yeah. How about the B vitamins?
Well, I think a prenatal vitamin in general, and good nutrition,
Right.
non-inflammatory nutrition. I mean, I think that's best, keeping your ideal body weight as close to possible, exercising, keeping your stress down. I think so. It's a number of factors, not just, the vitamins you take.
We're getting a few questions on Instagram as well. So about progesterone. So we talked about it a little bit on, we have a patient who's undergoing her frozen embryo transfer on Friday. How can she naturally increase her progesterone level? I think the question was that there was a threshold where you want to see progesterone prior to a transfer. Is that correct, at 20? Or is that, very important since she will be doing progesterone injections?
Well, I mean, in our practice, typically, the progesterone levels are really elevated. I mean, we never see progesterone levels under 20 who are on IM progesterone. So
I think she's not on it yet. So she's about to go on it because she's having her embryo transfer.
Okay, so IM progesterone will bring it up there.
She shouldn't have to do anything.
As long as they're monitoring your endometrial lining development before your transfer,
okay,
and it's appropriately thickening, and that's a whole debate too. But most people look at an endometrial lining. They have a couple of ultrasounds before they get a transfer. So
hers is 8.5.
Yeah, that's perfectly adequate.
It actually came up. We did an acupuncture treatment and it went up 1 millimeter.
That's perfectly adequate.
So that's good.
So that shouldn't be an issue.
Jessica says, what are some important factors to take into consideration if diagnosed with endometritis? That's a big one. We've seen that a lot lately.
Yeah, we get a lot of that.
Mm-hmm.
Well, endometritis, not endometriosis.
Right.
Okay, endometritis is inflammation inside the wall of the uterine cavity where the babies go.
Okay.
Not the outside of the uterus, it's inside the wall.
Okay.
And we typically look for it in probably everybody when they're trying to conceive who comes in for a diagnostic workup. We do an endometrial biopsy and we I'd say probably 5 out of 10 people have it without necessarily knowing it.
Okay.
People may be totally asymptomatic with it, or they may have very vague symptoms of spotting, brown spotting all the time, or a vague feeling of fullness. Maybe it's just a low-grade uncomfortableness in the lower pelvis, but typically no symptoms. The bacteria that we look for, is a special panel of bacteria that they look for being abnormal, which means that the lactobacillus is being overrun or by these other bacteria such that, there probably is an abnormal growth inside the uterine lining. It might be coming from vaginosis. I mean, there's a lot of theories about this now.
How does it get there? Yeah.
Nobody knows for sure yet.
Huh.
And people are starting to unravel, which types of bacteria are more important in the endometrial lining versus vaginal. I mean, there may be lactobacillus that's important in endometrial linings now. And, so there's all sorts of theories on that, and that's all being worked out. But, obviously the thing is we're going to have to treat it with antibiotics, repeat the biopsy, make sure it goes away, but also you must improve your intake of probiotics.
During the antibiotic treatment, you recommend probiotics?
Oh, absolutely. And
okay.
then also extra yogurts, things like that, to try to increase the lactobacillus amount.
Okay,
So,
because some people do not take the probiotics while they're on antibiotics, thinking that it's counteracting each other, but that makes sense. So then are you giving the patient also probiotics with the antibiotics?
Yeah,
okay.
for sure.
Okay, because and then I know that sometimes a certain antibiotic might not work. They have to try another one, and it can be resistant.
I mean, it's a hard thing to treat sometimes, and they may require several treatments, even 2 antibiotics at once. Or sometimes we have to operate. We have to do a hysteroscopy to actually see what's causing it. I mean, sometimes there are surgical causes of it. There's a little bit of retained tissue from a previous pregnancy loss, for example, or polypectomy. There's an adhesion in there causing it. There's something. So obviously the history is important too.
Okay, so that's important to look at diet. Just to ask, should diet be looked at incorporating probiotics, Jessica? That's important.
Yeah.
And then looking into stress without having. I mean, it definitely can flare up inflammation. I think it's an inflammatory condition. But the scary thing is you don't even know you have it, and then are other clinics testing for this, or?
I don't know. I don't know what they do. I mean, I'm of the feeling that I'd like to look for things as much as I can ahead of time, especially people who are, going through an expensive process. You want to make sure you try to improve their outcome as best as possible. It's not just, the egg and the embryo. Well, that's a big part of it, obviously, but the egg and the embryo has to implant, so it has to have a healthy environment or a healthy house. The house has to be neat and clean.
That makes sense.
So it's important to look for that, because if somebody has a miscarriage and you go back and you find something like that, you may assume, although it's not 100% clear, that might be a contributory cause. So it's better to look for it ahead of time, in my view. And
sometimes it will delay the process about a month or two, but it's worth it to wait.
It does. It delays the process, but I think for a good reason.
And we've seen many patients who they were diagnosed with endometritis, was treated, and they became pregnant during that trip with the transfer, and maybe that was hindering them in the past. So, because it can kind of linger, right? Or if it's not treated.
It can, and you got to make sure you got to make sure you prevent it from happening again. With good diet and nutrition.
We're getting so many questions. This is awesome, guys. We're on Instagram and Facebook. So if we're reading the questions from both. If we look like our eyes are kind of jumping around. So Jessica, I hope that answered your question. And then Anita says, hi from Nicaragua. I'm an Iserman ex-patient. Now I have 3 kids. Thanks, S-Firm. You used to be S-Firm.
Right, we're IVFMD. IVFMD.
Awesome. Congratulations, Anita. And
I'll say hi to Dr. Eisman for you.
Yeah, I think he joined actually. He's here.
He's here?
Yeah.
Is he?
Hi, Dr. Eisman. It looked like he popped in. And then Radha, I'm so sorry if I can't pronounce your last name correctly. Radha says, I have a whole fertility protocol from Standard Process as a fertility acupuncturist of exutropin, thyrotropin, and D3. Okay, so let me see about too much. You speak my language. Okay, good. Well, I'm not sure what the question is, but I'm glad that you're addressing, you're using Standard Process. And if you want to jump in with a question, let us know, but thank you for piping in. And then, okay, Sharina says, do you suggest acupuncture the day prior, on the day of, or after transfer? Does it increase the chances of embryo implanting? So we do actually recommend on-site acupuncture if you can have that done. And I think you guys have seen that work very well. And we actually meet with the patient 1 hour prior to the transfer, and then actually perform the acupuncture on site for 45 minutes. And we actually then wait until the transfer happens, and then we come back into the room and do the post transfer acupuncture. And, that's usually about a 25-30 minute treatment, because at that point, the patient really needs to go to the bathroom usually. So that's usually what our protocol is. But then we see our patient back about 5 days after the transfer, giving everyone time to rest. And we treat until the ultrasound. So it's a heartbeat. We actually treat twice a week. And that's for a lot of reasons. There's a lot of anxiety in addition to waiting for the pregnancy test. We work with blood flow a little bit, and it's an important time. We actually treat our patients as if they're pregnant from the day of the transfer. And so we are doing points that are actually specific to pregnancy. So that's really what I would suggest that we do. If you don't have acupuncture available at your IVF center, then you can speak to the acupuncturist about doing a treatment as close as they can get it to the day of transfer. Perhaps it's going to be the day before, but I think that something is better than nothing in that case, and it's good to do. I wouldn't suggest driving to the acupuncturist after a transfer. Sorry, I got dryness in my throat. I've been talking all day. I wouldn't suggest driving directly to acupuncture after a transfer, because I feel like it's good to rest. And there was a study that showed that success rate was actually a little lower when someone actually drove to their acupuncture straight after the transfer and did it, because those points are not meant to be used at a certain time period after transfer. Those points are actually kind of, contraindicated, the ones that are used at transfer, if it's used beyond the time allowed during that time, because that's used to actually calm the uterus after the transfer. So you don't want to use those points at a different time point, perhaps hours later, because that will not be as effective. So that's what I would recommend. Yeah. And And also doing acupuncture prior to the transfer for twice a week for 6 weeks actually showed improvement also in research that was done with acupuncture and IVF. So I think that if you can start a little earlier, it's better than someone who is calling saying, I just need acupuncture the day of transfer and that's it. Sometimes we wish we had a little bit more time to work with them. Jessica's asking any suggestion of probiotics to take. Pharmacist says no dairy with the doxycycline. There's a dairy-free probiotic from Pure Encapsulations. So that's a good brand. I think that you can look for them online. You can go to the Pure Encapsulations website and they have a dairy-free probiotic, unless you guys have a specific one that you recommend or.
Oh, I think that's a good one. We have some in our office. I'm not sure the actual brand, but I don't know if they're dairy-free or not.
Okay. All right. Jessica says, thank you. Okay. Thanks. Rada says, awesome conversation. I agree with every word. And then she's in Maryland. She actually does acupuncture 4 to 6 months before IVF. And then we're going to get to some questions on Instagram. There is someone who is actually saying, how can I increase chances of implantation?
Wow, that's a huge question. Are you doing IVF? I mean, it's hard to know what you're doing and your situation.
I'm just looking at, okay, this is the one with low progesterone, and she is doing acupuncture. So she's already doing that. She's taking all the supplements.
Right.
And
the stress reduction.
All of that.
Look for inflammation. Make sure you don't have inflammation going on. These are the things that you need to look for. And obviously, do you have a good quality embryo? Do you have a normal embryo that's been biopsied and it's deemed to be PGS or normal chromosomally? Are you getting enough progesterone? These are the things you have to look for.
And then, okay.
And is there any immunologic issues? And is your thyroid normal?
I like to also, we do a treatment called Mayan abdominal therapy, which is just like a lower abdominal massage, and also works with the lumbosacral area for alignment. And sometimes we find that the uterus does shift. It's suspended by ligaments. So if someone has a retroverted uterus or it's tipped, it can also be harder to get the catheter in. We're doing an IUI or IVF. So sometimes we actually work with this treatment as a centering sort of treatment, and that does help increase blood flow as well. And that's where we see, according to ultrasound, we see a difference in the lining, sometimes by 1 or 2 millimeters. So if the lining looks really nice, and I guess trilaminar or has like a nice look to it, a nice fluffy cloud for the embryo to kind of sink into, I think that's really a great scenario for implantation as well.
It's a very complicated issue. I mean, that's the big issue in the field is how do you improve implantation?
Remember,
everybody wants to know that and have that answer. I mean, but it's going to have to focus on various things. I mean, it's really 3 things. It's it's a good embryo, obviously. You have to have good uterine environment or normal endometrium, and it's not thin and plenty of progesterone effect, obviously, and plenty of and no immunologic issues. I mean, these things all have to come into play and will have to be looked at, especially if you have recurrent miscarriages, if that's your issue.
And I think that, there used to be something way back at like 10 years ago with embryo glue, right? And that didn't work out so well. There's no way to force implantation. I feel like it does. You have to think about it like, caring for the soil, like we said, like trying to prep a little bit beforehand, which is what I think you're doing, because you've gotten everything, like you've gotten, she's worried about her progesterone. That was the one with a little bit of a low progesterone. Right. But again, if you're going into a transfer with low progesterone, you're able to get the progesterone back up, of course, with the injection. So, okay, so there's a question about, is there any relation to ADHD and IVF medications? Can fertility drugs cause ADHD? Do you have any research on that?
Not to my knowledge.
Okay. And I haven't heard of that either. Genetic testing is a must. Testing killer cells in a woman's blood to help the IVF process. So that's something that you guys look at too, the autoimmune issues. And sometimes certain clinics will test for those issues as well. We are actually getting to the end, but Michelle says, I did acupuncture with her before my IVF treatment. I'm forever grateful to her. Hi, Michelle. Thank you for coming and joining us. So I'm really happy to answer you guys' questions. I'm looking on Instagram and everyone says it seems to have their questions answered. It's been really fun tonight, guys. If you have any questions at all, you can actually go to Messenger on our Facebook page, or you can direct message us on Instagram, and we'll respond to you. Both of us provide consultations. And then if you have any really specific questions, that's probably better answered like one-on-one instead, or if you feel more comfortable speaking to us.
If anybody's out of town, we can do virtual consultations.
That's true.
Through our office. So you would just call our office if you're interested.
Yes. And we are actually coming out with our PCOS online program as well through our Florida Complete Wellness. That is at thepcosrevolution.com. And there's actually a free IVF prep guide there if you want to look at that, not just for PCOS, but for anyone trying to prepare for a medicated cycle. So that's thepcosrevolution.com.
And I would urge all of you to look at this because it's a fantastic program. It's very comprehensive.
Thank you.
It's incredible.
I appreciate it. So I look forward to hearing from you guys. We'll have to do this again, and I really appreciate all your questions. I hope that helped, and have a great night, everybody.
Good night.
Bye, everybody.
If you enjoyed listening to this episode, you have to check out the PCOS Revolution Academy 90-Day Reset, where we go through all of these topics in an easy-to-follow, totally online, step-by-step process so you can stop giving PCOS the upper hand. Join me over at thepcosrevolution.com to find out more about how you can sign up and also get access to some very cool freebies that I've created for you. I'd love to have you join me inside of the Academy. See you there and have a wonderful week.